Good afternoon, everyone. I will go ahead and call the Treatment and Recovery Subcommittee of the statewide Substance Use Response Working Group to order. And first item on our agenda is our roll call to make sure we have a quorum today.
All right, Assemblywoman Thomas.
Here.
Chelsea Cheatham.
Present.
Dr. Dixon. Steve Shell.
Here.
Jeffrey Iverson.
Here.
Dorothy Edwards.
Here.
Mr. Chair, we have a quorum.
Okay, great, wonderful. Next item is public comment, so please bear with me as I make a statement. Public comment will be received via the Zoom meeting. Public comment shall be limited to 3 minutes per person. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. So Kelly, I'll turn it back to you to see if we have any public comments.
That's great. And just a note, did you read both the phone number and the webinar ID, or can I do that for you?
Yeah, please do that, Kelly. I'm sorry.
Okay, great. So just a note, you can raise your hand and unmute yourself if you would like to make public comment. You can also dial 1-253-205-0468. And when you're prompted, the webinar ID is 894-893-75298. And you press *9 so the host can unmute you. So I'm looking to see if there are any participants on this call who would like to raise their hand or unmute. Dorothy Edwards, Mr. Chair, has raised her hand.
Thank you. I'll turn it over to Dorothy. Hello, Dorothy.
Hi there. For the record, Dorothy Edwards. I am the Washoe Regional Behavioral Health Coordinator. I just want to remind everyone that next Monday, April 8th from 3 to 5 is the Washoe Regional Behavioral Health Policy Board meeting. We are beginning to hear BDR pitches, if you will. I believe we have 2 scheduled, one that is substance related from a gentleman at UNR who is wanting to discuss Narcan on college campuses and in dorms. And then we have another presentation by the Board of Psychologists. And so just wanted to encourage your attendance. It is virtual, and I have posted the agenda, but should you have not received it, please reach out to me or Chair Shell, who is also the chair of the policy board, and he and I will be sure that you get that agenda. Thank you.
Thank you, Dorothy.
Mr. Chair, Lisa Lee has her hand raised.
Great. Hello, Lisa. Great to see you today. I'll turn it over to Ms. Lee.
Hello, everyone. Good afternoon. Good to see everyone. I also see that our president from the Northern Nevada Harm Reduction Alliance is also on the call. On behalf of Northern Nevada Harm Reduction Alliance, I just wanted to update everyone that our Bad Batch app is up and running. It is called Safety Outreach System, and it is available for download on the Android Google Play Store. We anticipate that we'll also put it up on the Apple Play Store as soon as we sort of pilot it on the Android side of things. So I just wanted to give an update that that's up and running. And if anybody in Washoe County would like cards dropped off to your organization to maybe give to folks who might be discharging or who might be still using, it has a variety of resources within that app. And I'm happy to drop off cards with the QR code for that app. Thank you.
Thank you, Lisa.
Mr. Chair, I don't see any other hands raised or persons unmuted to make public comment.
Okay, thank you, Kelly. We'll move on to item number 3 in our agenda, which is to review and approve minutes from our October 23rd, 2023 subcommittee meeting. Hopefully everyone has had a chance to review the minutes. And if so, we will entertain a motion to approve.
This is Jeff Iverson. I'll make a motion to approve.
I
Thank you,
second.
Jeff. Do we have a second?
Second, Dorothy Edwards.
Thank you, Dorothy. Do we have any discussion regarding the minutes? Hearing none, all those in favor of approving our minutes, please say aye.
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 Any opposed? Great, motion carries. Thank you. Moving on to agenda item number 4, the 2024 Subcommittee reorientation. I know that it's been very important to Attorney General Ford and others on the full SURG committee that we have a very active, robust committee again this year. And so I think he's just wanting to ensure that we have all of our committee members are very actively engaged in the process and participating and submitting ideas and so forth. So I know today we wanted to go through some of the expectations for this year, just to make sure that we're all on the same page and understand what's really being asked of us. And I think, Kelly, do you have the next slide where it's focused on attendance? There we go. So beginning this month, actually, attendance will be tracked, and any member who goes below a 75% attendance rate for either subcommittee or this full SURG working group meetings will be asked if they wish to continue serving. And this will count for both excused and unexcused absences. So going forward, if you are not able to attend a meeting, we are asking that you please email someone on the SEI staff at least 4 business days in advance to ensure that we will have a quorum, or rescheduling the meeting if necessary. And please also submit this advance notice for an excused absence as well. Anything to add to that, Kelly?
Mr. Chair, I just wanted to note for the record that Dr. Dixon is joining. So I just wanted to note that her attendance should now say that she is present, and I will mark her as such.
Great, thank you. We're glad Dr. Dixon is with us. Any questions about the attendance? Okay, moving on to recommendations process. I think everyone understands that why the subcommittees were set up a year or so ago, and it really was so that we could have smaller working groups to be able to make recommendations to the full SURG committee. So we just wanted to go through some of the expectations of that recommendations process. So Kelly, did you want to go over the survey review?
I can, yes. So I think that's fine. So we have a survey available in SurveyMonkey. And for those of you who have been on the committee before, you will remember this is your favorite survey. By the way, Kelly Marshall for the record. So the survey, I'll put the link, I'll pull the link up. So if you give me a second, I will stop sharing. But I wanted to note that one of the things, now that we have some history of recommendations being received for multiple years, we're getting a sense of, like, are we getting recommendations just from one person? And for the most part, this subcommittee has been very collaborative with multiple members submitting survey responses or responses in the meeting. And what I mean by that is that if there is a recommendation you want to make, there is some baseline information that consistently has to be collected by the time the subcommittee is done reviewing the recommendation. And so I'm going to share that with you so that we can review that together. And I will do just kind of a mock, so you can kind of see how this works. All right, so I am going to pretend that I am our former chair, Assemblywoman Claire Thomas, right? So the first thing you do is you submit your name so that we know that the recommendations are coming from a subcommittee member. And then we ask that you describe the recommendation. If you have multiple recommendations, you'll fill out the survey multiple times. You'll go into it, you'll click your name again, and then you'll fill out number 2 for both. And then if you recall, in our most recent annual report, which was provided to the governor and the legislature and DHHS director in January, each recommendation has a justification. So we ask for a justification from you, and sometimes it's narrative that just says, in my practice, you know, I know that there are a considerable number of people who lack access to medication-assisted treatment, or it could be links to research or studies, anything that you want to provide as a justification for the recommendation that would allow other people to more fully examine that recommendation and support it or ask questions about it. And so then there's a place for any research links. We then ask that in alignment with AB 374, which is what established the SURG, Section 10 of that legislation, identified things that had been assigned specifically to treatment and recovery. So if your recommendation hits on multiple things, you would just note that. So if we were talking about the MAT recommendation, we might click on like letter E because it's about expanding evidence-based or evidence-informed programs, procedures, and strategies to treat and support recovery from opioid use disorder. Then there are what's called the items A through Q, which are so that's kind of what the basis of this is, but there are cross-cutting elements that are assigned to all of the subcommittees. So if you are also trying to address something for members of special populations, let's say you say, we know that pregnant women are particularly at risk and need access to MAT and sometimes receive barriers. You may say that you're going to add that to your recommendation, that it will specifically address pregnant women. And then you would say, this is also focusing on special populations. So you would click that. And then you can select, okay, it's actually addressing pregnant women, but let's say, I also know that medication-assisted treatment addresses people who inject drugs, LGBTQ. It's relevant for people who are incarcerated, not really relevant for children involved in the welfare system. And so those are the ones that I select. And then we pick an action step aligned with your recommendation. So what is it that you think? Is it that a policy needs to be changed? Is it that you're asking for expenditure of opioid settlement funds? Is this regulatory or licensing? Are you requesting a bill draft? Or is there some other action that you think would help address this? So in this case, I'll just click on expenditure of opioid settlement funds. Is this a short-term or long-term recommendation? And by that, we're talking about, is this something that can be implemented right away? So under a 2-year period of time. So sometimes with funding, you know, or let's say it's a bill draft request. Is that going to be in the next 2 years? Yes, it is. If it's longer term, if it's something that is a change to, for example, the Medicaid state manual, that might take longer. And so you might click over 2 years. And if you're not sure, you say you're not unsure. If your recommendation requires a fiscal note, so let's say we're saying we want to increase funding, then we would say, yes, I think there's an estimated fiscal note, but maybe I don't know what the dollar amount is. And so I can either estimate it or I can say, don't know. And then we're looking at factors to rate the impact of the recommendation. So how impactful would it be? In other words, how many people are impacted and what would the impact be to the community at large? And so you're moving somewhere along there. And then you can describe that impact. How urgent is this? Is this, you know, something where people are overdosing and there's a great lack of resources? Then you might say that's very urgent. And then what is our current capacity and feasibility to implement the recommendation? So it might be there's some capacity, it depends on the funding. And in each case, if you have more information to provide, you provide it. And then we're very interested, if you recall, we had a SURG meeting on health equity in the January 24 SURG meeting, or during the January 24 SURG meeting. And so we're also asking, can you provide a description of how it advances racial or health equity? And then do you have any suggestions for a presenter? Now, not everybody who has submitted the survey has always had ideas about who a presenter might be. And so you fill out the parts that you can. And now it's telling me, oh, I need to go back because these are required, like there is no recommendation. So I'm just going to X out of that and bring us back to our presentation. But that is the survey. So what we're hoping is if people already have a recommendation, and maybe I'll just use Dorothy Edwards as an example. Let's say, Dorothy, you are currently evaluating bill drafts, right? And so your policy board may say, you know, we're not quite ready to do a bill draft on this, but we know this is important. Then making a recommendation through this subcommittee as an alternate approach, right, to elevating that idea that your board appears to be supporting, but you may just not have enough bill drafts for. So as our newest member, I thought I would raise that because I could see that applying for you.
Yes, thank you. I was just, my wheels were spinning like, how many can I put forth for consideration or thought? So I appreciate that greatly.
And so prior to every meeting, we will look at the survey results. In other words, this is not a one and done where you have to get all your recommendations in by April 30th. However, what tends to happen is that the later we get a recommendation, the less likely it is that it will be able to be included in deliberations with the full SURG by October, which is when we're targeting that. So if we have a meeting in July and you're raising, you know, an issue, then we may not get a presenter in time for another meeting, or you may not have all your questions answered or the questions of the rest of your subcommittee peers answered. So the earlier that recommendations are submitted, the more time we have to schedule those subject matter experts or even identify them and refine the recommendations. So we will continue to remind you all of that, but just wanted to note, we will send this link out again and start collecting recommendations. And we have some carryover ideas from last year, things that didn't quite move forward or that people have raised already. So I'm going to share those as well. But submit your ideas as early as possible. We're hoping that we would have at least one recommendation from every member. And our next agenda item is going to review the areas that you addressed in the 2023. And then we will come back to some of the ideas that were carryovers. So I think that that kind of concludes that part of that agenda item.
Thank you so much, Kelly. Does anybody have any questions at this point on how to submit a recommendation or a suggestion for a presenter before we move on? Okay, thank you. So next item on our agenda is number 5, to review subpopulations at AB 374 Section 10 requirements addressed in the 2023 recommendations for possible action. Kelly, I'm sorry to have to call on you again, but are you able to walk us through? We've got quite a bit of content here, and I thought it might be helpful if you walk us through this.
I would be happy to.
Thank you.
Okay, so the aforementioned items A through Q in AB 474, that's what legislatively laid out what the SURG does. And then for members of the public, if you have not been in prior subcommittee meetings, 3 subcommittees were established. So with guidance from members at that time, and in that case, it was the then SURG Vice Chair, Assemblywoman Tolles, then Policy Advisor for Behavioral Health, Dr. Woodard, and our current and former, our ongoing person, Dr. Kearns, got together. They were empowered by Attorney General Ford to get together and come up with an approach. And that resulted in 3 subcommittees. So there is a prevention subcommittee. We are currently meeting as part of the treatment and recovery subcommittee. And then there is a response subcommittee. And from the first time those meetings started, we divvied up everything that was in A through Q, or Dr. Kearns, Dr. Woodard, and Vice Chair Tolles. Divvied those up and assigned them to one of those 3 subcommittees. It then became clear that people were uncertain about where harm reduction should go. It was later determined that harm reduction would go under the prevention subcommittee. However, this subcommittee has brought forward recommendations that were both treatment and recovery and harm reduction. The same thing is true for response. The same thing is true for prevention. So it's not cut and dried in that way. Everybody should have received the treatment and recovery 2023 recommendations and legislation addressed handout of this agenda item. And I will stop sharing and pull that up for you as well. But if you went to the meeting postings, you would see it there. And it looks like this. I will make that a little bigger for you. Okay, so here is the language. Here we have prevention. And then here are the items that treatment and recovery are asked to address. And if you recall on the survey that we were just walking through, there was that section where it said, which of these things does your recommendation address? Does it address item C, which is to assess and evaluate existing pathways to treatment and recovery for people with substance use disorders, including without limitation, people who are members of special populations? So if the answer is yes, then we're addressing that recommendation C, or that area C. Area E is to evaluate ways to improve and expand evidence-based or evidence-informed programs, procedures, and strategies to treat and support recovery from opioid use disorder and any occurring substance use disorder, including but without limitation among members of special populations. And you recall in the survey that we just looked at, that list of special populations was also provided so that you would know who are we talking about. And then item F is to examine support systems and programs for persons who are in recovery from opioid use disorder and any other co-occurring substance use disorder. So you can see prevention is up there. That's what treatment and recovery does. Response does the following items. And then we already mentioned on the survey the cross-cutting strategies, but there you see them again. And under C, A through G, you see the special populations listed. So in addition to the 3 above, your recommendation could address B, C with detail for the special populations, H or Q. And in the most recent SURG report, we noted this table, which was part of the report itself. So this is for treatment and recovery. And where you see under the subcommittee header, it says TR. You can then look and say, okay, recommendation 2 addressed from A through Q, addressed B, C, E, J, and X. So what we're interested in is, are there any areas that have not been addressed by any of the subcommittees that fall within items A through Q? And when you look at this table, you can see that the main area that has not been addressed is item L. So there's a reason for that. If we go back up to L, it's very specific and says to evaluate current systems for sharing information between agencies regarding trafficking and distribution of legal and illegal substances, which are associated with substance use disorders, including without limitation, heroin, other synthetic and non-synthetic opioids, and stimulants. So there has not been a recommendation from any subcommittee thus far addressing item L. So this is just a way for us to be accountable to say, okay, we are charged by the legislation with doing our work, and our work at a minimum, right, is to address items C, E, and F. But there are other elements that our recommendations may cover. And you can see that there have been a number of recommendations that address C, or fewer that address E, and then some in our most recent that addressed F. So those those 3 recommendations did. And if you wanted to look at the full recommendation, you could say, okay, so this was a treatment and recovery recommendation that addressed not just item C, but it also impacted B, J, and Q, as well as E. So you could scroll through that handout and see for every treatment and recovery recommendation, how are we doing our job? Now, the next treatment and recovery recommendation is under number 4, and you can see that it was predominantly focused on C and E. And when you look at the recommendation, you can understand that because it's very specific, right? It's talking about diverting youth under the age of 18 that are at risk of a higher level of care or system involvement. And it's really specific to treatment facilities and beds for intensive care coordination. So it's not addressing everything in the legislation, nor should it. And so we just wanted to reinforce that it's not always that more is better, because some recommendations are very specific, and the more specific they are, the more actionable they are. And so there isn't an expectation that we would be checking every box across this, because then the recommendations would be so broad, they would be almost impossible to implement. But we wanted to just provide this for your understanding, so that you would have a sense of how we are doing in terms of doing our work. And I would just kind of, to close out this part of the presentation, I would just say that like recommendation 6 that was in our most recent report was talking specifically about a child welfare service delivery model that addressed both children and adults. So it addressed adults who are affected by perinatal substance use and their children. So we hit 2 different subpopulations, as well as pregnant teen or birthing people. And it was impacting service delivery models. So we were trying to make changes and improve access to treatment. So we just wanted you to note that this is available for you. This is all of the recommendations. It goes beyond just treatment and recovery. It includes every recommendation that was in our most recent report. And then if you wanted to focus even further on the subpopulations, you can see what subpopulations the recommendations impacted as well. And again, I would just note that the subcommittee that you're interested in is TR, which is treatment and recovery. But if you wondered, oh, so who specifically, what subcommittees are addressing people who inject drugs? You would see, oh, all of the subcommittees are, okay. So that is part of what we wanted to share. And for other subcommittees, I would just note that a number of them have had interest in revisiting recommendations that they felt like did not get moved forward. This subcommittee is different in that you basically refined almost all of your recommendations last year, as well as brought forward some new ones. And so while some of the other subcommittees are going to be going back to recommendations that they talked about last year that maybe didn't get into the report or didn't result in a recommendation to the full SURG, that is not actually the case with your subcommittee. Your subcommittee refined a number of recommendations to make them clearer or more specific. And so we're really going to be looking for new recommendations from this subcommittee. So the other thing that I would note is, and I think Chair Shell is going to kind of pose the question of where do we go from here? So we also have some notes from Laura Hale, who has been doing our minutes and keeping us on track for the last 2+ years. And I can elevate for you what are the things that have been raised that we have not yet made a recommendation for, or that you may want a presentation as a starting point, potentially for that that discussion, and we'll address that under agenda item 6. So that was the reference to the treatment and recovery 2023 recommendations and legislation addressed handout. And there you see the 3 areas that are assigned to treatment and recovery. There's the cross-cutting. So this is also in the PowerPoint slide. And then you have the summary tables. But what we did is looked at your recommendations. And so these are the recommendations that you submitted in the 23 report that was issued in 24.
Are you meaning to share the screen, Kelly?
Oh, I am. I'm sorry. Thank you, Laura.
Sure.
Sorry, I started and stopped so many times. So excuse me. So these are the recommendations that you submitted last annual report. So the expanding access to MAT, increasing the capacity for treatment facilities and beds, specifically to divert youth under the age of 18, the specialized child welfare service delivery model. We had a recommendation specifically around establishing priority funding areas to ensure entry into treatment and recovery for Black, Latino, Indigenous, and people of color, as well as LGBTQIA communities. 1, to ensure that they're receiving culturally and linguistically appropriate overdose prevention, but also drug checking supplies to reduce fatal overdoses. And then we had a recommendation around peer recovery support specialists based on Foundations for Recovery's presentation to us, recommending that we engage individuals with lived experience in programming design considerations and enhance peer support for underserved populations. And so some of the strategies listed were also part of that recommendation. So I would be happy to answer any questions, but I'm hoping that between the survey the review of legislation, and the review of the recommendations that were submitted for the 2023 report, that people have a sense of where we left off our work so that now we can start our next slate of work.
Thank you so much, Kelly. Does anyone have any questions or comments at this point? Okay, hearing none, we'll move on to agenda item number 6, which is planning for the 2024 Treatment and Recovery Subcommittee meetings. And I just wanted to make note that we really would like for this to be a very open discussion right now among our committee members to answer the following questions. What would we like to accomplish this year? What is our vision for developing recommendations? And as Kelly said earlier, should we start with last year's presentation where there wasn't time to develop recommendations for 23, or should we focus on creating new recommendations, which, would be my recommendation? And then where do we want to be by September, when the SURG working group will begin narrowing down the recommendations to include in the annual report? So on that note, I'll open it up for discussion and see if any of my fellow committee members would like to kick off our discussion.
I will.
Yes, Dr. Dixon, I'll turn it over to you.
Sorry, I was late, but anyway, I'm going to just put out what the problem that I see is becoming a big problem is, since I'm an active treater, we're seeing patients, we're taking care of patients, but the overdose rate is going up and up in spite of, and so we really need to do a better job in getting it out there that treatment is available. I think that's one problem, is that a lot of people don't know that treatment's available. And the other is that how can we, and I see a lot of fairly young people, not teenagers, but young 20s, in their 20s. And these people are not really all that interested in treatment. They don't want to stop. They have learned how to make using fentanyl work for them. They're not terribly afraid that they are going to get the wrong dose. They must have dealers that they somewhat trust, and so but there's still mistakes being made because the overdoses are going up. But I was really wondering if it would be worth having the coroners from the North and South talk to us a little bit more about what they see, what information they were able to gather following an overdose that might be useful in terms of, like you say, recommendations. Where are we missing the boat, I guess, is the question.
That's an excellent point, Dr. Dixon. And I think that, like you said, that would be very helpful to bring the coroners in. I think that's a great idea.
Steve, Chair Shell, this is Dorothy Edwards. For
Yes,
the
Dorothy.
and admittedly, as a new team member here, I may not know what I don't know, but as I think about other boards and other organizations where we put out recommendations, we work hard. Our policy board's an example, and we put them out there in the universe, and sometimes we can act on them, sometimes we can't. But before we develop new recommendations, I guess, and maybe, we're doing this, I kind of want to see, well, where did our other recommendations go? If we were passionate enough to put them out there and talk about them and massage them, then where are we? Are we still passionate about them? Do we need to tweak them? Did they die? Did someone else take them up? So I guess before we develop brand new ones, where can I see how we did on the other ones? And as to Kelly's point, or someone's, there wasn't time to develop some, and so that would just be my recommendation, use that word again, is to think about, before we do a whole new slate of new ones, where are the ones that we were passionate about, and what have we done so far? So that's all.
And I think you raise a great point, Dorothy, because for those of us that were on the committee last year, I think there was a lot of passion about sticking to the previous recommendations and refining them as we did. So I think that's an excellent point to go back and revisit because we have had such passion about those recommendations we raised.
This is Jeff Iverson for the record.
Yes, Jeff.
Hi, everybody. I just want to follow up that is a great recommendation to know that the time we're spending developing these recommendations, like are they is anything coming as a result of that? Like it would be nice to see the fruits of our labors. One of the things that I'm noticing as a person in long-term recovery is that there's the appearance that some of the managed care providers that oversee Medicaid dollars do not make it very accessible for people that are really in need of treatment to get the help that they need. I don't know if Dr. Dixon has any thoughts on this, but I'm seeing that there's a lot of money devoted to this cause. I'm also seeing a lot of people being denied access to treatment and services for a variety of reasons, which it would be very interesting to find out if there was any kind of an audit on Medicaid dollars that are being spent in the behavioral health and substance use space and how it's being spent. Just an observation.
Yeah, just to add to that, Jeff, I'm so glad you bring that up about Medicaid, because I do know that, we've had lots of entities around the state that have gotten major rate increases over the last year, but yet we still don't have the access to care.
I'm
Some of
telling
that's
you,
still lacking. So
there are some managed care providers that are really good about getting their population access to the types of care they need, and there are a few that are exactly on the opposite end of the spectrum. And I don't know what we could do, or if this is even the appropriate place to have that conversation, but it seems to me that if we're providing recommendations around this issue to the SURG committee, this certainly should be a topic that we could dive into a little bit, because I know firsthand that there are a lot of people that need access to care who are being denied, and they're shuffled around and sent to emergency rooms or shelters and given bus passes, told to go to outpatient clinics, and we're just, for the amount of resources available, I do not think that the population is getting the treatment and the services that they need. So that's my 2 cents for this moment.
well, one thing I also wanted to share that I was going to bring up for the group, Jeff, is I wanted to mention that I would like to see us talk a little bit more this year about the regulatory piece, because I've had it brought to my attention recently that when a provider is trying to get credentialed with Medicaid, for instance, psychiatrists can get credentialed very quickly, but therapists are taking months to get credentialed. And so
Right.
I just think that that's, something that has to be addressed too. And I think and that goes back to what you said earlier about the access to care. We have individuals wanting to serve the Medicaid population, but yet they're not able to get credentialed in a timely manner. And a lot of them just give up, or they've had to move on to other forms of, revenue.
There are really well-intentioned people in this industry trying to do good work and trying to help this population. And there are definitely people putting hurdles and roadblocks unnecessarily up in an effort. For me, it appears that they're just it's a control thing, and I just think there needs to be some light shed on that. Like it shouldn't be so clunky. The money's there, but people can't access care. You're right. Part of it is a credentialing issue. I know that there's, discussions and disagreements between clinical and medical personnel about what is appropriate. It seems to me I personally am aware of multiple overdoses in the last even few weeks, and families that are being ripped apart because they just really cannot get access to care. And it almost feels criminal at times that that I know that the resources are being provided, but the care is being denied, and we've got to somehow draw attention around that subject.
So, Dr. Dixon, for the record, it is strange. I have, patients will come in, we do an evaluation, we write them, we send a script off to the pharmacy they want to go to, and then they go to the pharmacy and the pharmacy says, oh, no, we don't take your insurance. And so then we have to start this. I mean, I just can't believe that this happened, that all of a sudden different insurance companies work with different pharmacies. That just was like almost the end of it for me. It's like, I mean, it's bad enough when the hospital starts choosing which insurance they wanted to work with, but for pharmacies to choose which insurance they're going to take and insurance they don't take, I was just like, to me, I didn't use the word criminal, but so we run into, there are things like that. And you can imagine what it's like for a patient who's finally made a commitment, a decision to come into treatment. They get the script that they come for, and then the pharmacy says, no, we don't take your insurance, or no, we don't have that. Or, and then sometimes they want prior auth, which is now against the law. That we passed the step therapy prior authorization. You can't do that with psychiatric and substance abuse medications, but they do it all the time anyway. And so how we're going to because the insurance companies are pushing back hard against this. And but the law passed, and so there's just so many little steps that things can go wrong. And so like what Jeff's talking about, and these kids, and I use kids because a lot of our patients are very young. They're ambivalent at best about getting treatment, and when they get a step or two in the way, they're going to go back to using, especially with fentanyl, because the high for fentanyl is very short, and you can't go too long without another dose. And so you push a patient off at 2 or 3 days, and they're going to be back to using.
I mean, I don't want to listen. I'm not here to promote, obviously, any of my facilities, but I can tell you that right now at one of my detox clinics, we're turning away 25 to 30 people a day who we know need medical detoxification, and the insurance company is saying it's not warranted.
Yeah, they don't want to pay for that.
And it's sad, and I don't know how to approach it other than make some form of recommendation that somehow we shed some light on the subject. I don't know. And I'm certainly not here trying to promote the facility that I run, but it's very disheartening and sad when we have to turn people away that I know need help. But for a technicality or a disagreement between a clinician or a medical provider or somebody in utilization review or somebody's sitting behind a computer and an insurance company says, no, they don't need it. They don't qualify. And the truth is, a lot of those people just go back out on the street, and a lot of them end up dying. So I don't feel like I've had very much of a voice on the committee up until now, and I feel like it's time that I just felt like I needed to share that with this committee today, that if there's some way to build a recommendation around this issue, in addition to looking at what we recommended last year, I see it as a big hurdle and stumbling block for a lot of people that need help.
So Jeff, on that note, do you have any ideas or recommendations on a presenter regarding this topic that we could bring in?
I sure do. I could definitely put that in my wheelhouse and come up with some ideas. It's very interesting. I don't know how much you guys are familiar with this, but there's 4 MCOs in the state, and 2 of them are very good about getting their population, their Medicaid people, the help that they need, and there are 2 that are extremely difficult to work with. And the Medicaid population is divided equally amongst them. There can't be that much of a difference between the ones who are providing the care and the ones who are denying the care. You know what I mean? So yeah, I'll think about somebody good to come in and present. But I'm not sure how much regulation or auditing goes on at the state level on how these Medicaid dollars are being spent, and how much of it is going into the pockets of shareholders versus how much of it is actually going to help the people that need the help save their lives.
Well, this is Dr. Dixon. It's been my impression, and what people have said is that, the Department of Insurance has no control over these MCOs. Once the money is dispersed from what is it, HICFA or whatever, they can do what they want with it. There's no auditing done. They can negotiate what they want, and and with who they want. And whereas fee-for-service Medicaid was a little bit easier to figure out where things were and have some influence on, the MCOs there doesn't seem to be any way to control them and tell them, at least that's what my impression. It may be wrong, but
well, that certainly seems to be the case, and there are certainly people putting a lot of money in their pockets while I watch people be denied access to treatment that they absolutely should be getting. So, Chair, back to your point, I will be thinking about somebody that could do a present on this subject if that's something that the group is interested in pursuing. It's a major roadblock to a lot of people getting into treatment.
Yeah, thank you so much for raising that, Jeff. And, I'm again, it kind of touches on what I was hoping that we would be, focusing on this year, or bring more into our focus about the regulatory piece.
Yeah.
I don't know how our fellow committee members feel about that, but I wanted to make 2 additional notes to what you've said, Jeff. The MCO contracts are going to be coming up for renewal, and I believe
Right.
it's in 25.
Right.
So the state's going to be preparing for that this year. So I think it would behoove our subcommittee to be discussing, any type of potential recommendation around that we could make to the state to either, consider different guidelines or expectations for those MCOs and others. And then the other note I wanted to mention is that our state is also moving towards making our entire state managed Medicaid. So that is in the works at the moment. I'm not sure the
Nice.
effective date on that, but again, I think you raise a good point about Medicaid. So I think it warrants further discussion for all of us if our fellow committee members agree.
Absolutely, I do.
And on that note, do any of our other subcommittee members have any items to bring up? Any other points of discussion? Anything else you would like to see for this year?
Chair Shell, would it be helpful if I were to just kind of do a recap of some of the things that we may have placeholdered or said we wanted to workshop this year?
Yes, absolutely, Kelly. Thank you.
Okay, so Kelly Marshall for the record. One specific thing that Assemblywoman Thomas brought up was provider training on alternative pain treatment, such as physical therapy, massage therapy, and acupuncture. And members specifically in 2023 said they wanted to workshop this in 2024. Like they wanted a presentation, they wanted to develop a recommendation around it. So that was from Assemblywoman Thomas. The entire group had kind of 3 different parts of a discussion, and I would just note that a person that I think we may want to hear from is actually on this call, and his name is Bill Teal. So let me just lay out what the group has talked about, and then Chair Shell, if you feel like you want to open up questions related to this, that would be an opportunity. But my understanding is that the Department of Health and Human Services is funding a survey on readiness for MAT in jail and prison populations. There was also a question about whether DHHS's 1115 waiver would support Medicaid benefits 90 days prior to release from jails or prisons, which is another kind of criminal justice component. And then I just want to make sure I didn't miss anything. We had reference last year to MIT's Educational Justice Institute that was talking about care coordination for treatment upon release from institutions such as prison or jail. So those are 3 kind of criminal justice pieces. But I think a presentation related to the survey on readiness for MAT in the jails or prison settings was something this group had asked for, potentially to develop a recommendation.
Is there any discussion around those items Kelly just mentioned?
With Dr. Dixon, one thing that from the last year's legislature is, there was a bill that mandated MAT in the prisons, and the prisons pushed back and said they couldn't really afford that, and so they dropped that mandate and they moved it to a study. So every jail and prison in the state is supposed to do a study and make a report. And I think, I don't know, is it due in June of this year or something? I don't know. And I don't have any idea if they have figured out how they're going to do these little studies. So the survey maybe would feed into those reports. I think the problem with expense is that they feel they would be better off to do the shots, the 2 shots of buprenorphine, either the Sublocade or Brixadi, and that way they don't have loose medications around, but those are expensive. They run in the $1,200–1,300 a shot, and anyway, that's what I know. I mean, as far as the jails, our company does deliver medication-assisted treatment to folks in jail who were already on it. I don't think we're initiating it at all. But patients who've been in the methadone or Suboxone clinics can have their medication delivered to them while they're in jail, as long as the jail, I guess, lets us know they're there. That's probably an issue there. So anyway, I think we need to know, and in other words, to go along with surveys, we need to know just who is doing what and what is not being done.
I wanted to go back and give Assemblywoman Thomas an opportunity if she'd like. I know she did bring up the subject of the treatment of pain in our previous meetings, and I'm just curious if she had anybody in mind that she may want to present to us this year. So Assemblywoman Thomas, if you don't mind. Yes, Kelly.
Sorry, Kelly Marshall for the record. It does look like Assemblywoman Thomas may be on the phone, but she did provide a name for a presentation.
Oh, wonderful. That's great, Kelly. Okay, I didn't want to miss out on an opportunity. Thank you.
And there were, Chair Shell, there were two other things. One, we had that presentation from Kaylin C on safe consumption sites. You know, we basically worked for 2 years to get her calendar to align with ours. So she presented on the work that she's doing in New York on those safe consumption sites and the street outreach that they do. And the group talked about wanting to potentially build out a specific recommendation for that in 2024. So that's another area that I just wanted to note. I think that may be it. Oh, there was also this subcommittee had some questions about whether we could reach out to DHHS for fiscal notes on recommendations and ask them to assist in the development of fiscal notes. And there was definitely focus on follow-up and referral for justice-involved individuals.
Great. Thank you, Kelly. So based on all of those that Kelly just recapped for us, how is the group feeling? Are you leaning more towards one or the other on what we should discuss at our next meeting or in our, subsequent meetings? Does anybody have any preference one way or the other? Strong feelings one way or the other? From what I heard a few minutes ago, Kelly, it sounds like, everybody seems to be in agreement about going back to just review our recommendations for 23 one more time, just to see, if those still align with where we are for this year.
So, and Kelly Marshall for the record, we can certainly prepare slides with those recommendations. I would just also note that in part of the 2023 report that was published in January, there was an update on previous year's recommendations where we had sent a request to DHHS and asked them, can you tell us what's happening in terms of funding or policy or legislation around these recommendations? That update for the previous year's recommendations are in that report, so I'd encourage people to review that. The ones that you just made in January, I don't know that there's any update that would be available now because they were just kind of codified and approved by you in January. But we can certainly review them.
And Kelly, I see Assemblywoman Thomas has her hand raised. I'll turn it over to her.
Thank you, Chair. Appreciate it. Assemblywoman Claire Thomas for the record. I just want to put in a request and for the group to have an open mind to alternative medicines, because what I've been learning here, especially through our veteran community, they are reluctant now to be medicated because, they feel like that's one thing adding on to another. So I would hope that we would at least, take a look at it.
Thank you, Assemblywoman Thomas.
So Chair Shell, I will be sure to send out the link to the survey so that any and all members are welcome to submit, a recommendation and then to also suggest presenters and topics. The sooner that we have them, the longer we have to be able to make sure that we get those presentations on our next meeting docket. Because really we have, you know, between now and July, and then we start refining really by the end of August, so that we can forward recommendations for the first look for the surge in September.
And Kelly, I wanted to clarify the group. We have one meeting between now and July, correct?
We do. I believe we have one scheduled in May.
Okay, okay. So I would ask our committee members to be mindful of that, that if you do have these ideas, that let's please bring those, you know, forward now so that we can get these on the agenda as soon as possible.
And based on so Kelly Marshall, for the record, based on the direction from the subcommittee last year, my understanding was that they did want to workshop the alternative pain treatment, and that I should follow up with the recommendation or the presenter that Assemblywoman Thomas provided and get that scheduled for me.
Yeah, that one sounds very critical, Kelly. You're right. So I'm glad we can hopefully get that on the agenda for May. Is there any other discussion today regarding the development of our recommendations or where we'd like to be later this year? I don't know about all of you, but I am sitting here thinking we don't have a lot of time this year because we're already getting ready to move into April. So we've got to make the most use of our time in the next few months, as I'm sure all of you will, including myself. So I just wanted to stress that. Okay, so if there's not any other discussion, we'll move on to item number 7, which is to discuss the report out for our April 10th surge meeting. And Kelly, I did have a question about that. I did not see that on the agenda for the full surge meeting that's next week, so I didn't know what this item might be pertaining to. So if you don't mind me turning it over to you.
Not at all. So we just wanted to note if there were any things that this subcommittee explicitly had decided on today that they wanted to share, that we would have an opportunity to share that. And in particular, I think what we're trying to do is just coordinate so that we don't have multiple subcommittees working on a similar recommendation. There were a couple of subcommittees, ours included last year, where the same presenter was suggested to present at 2 different subcommittees. So we just identified that and then made the recording available to the other subcommittee because we already had them scheduled to present for us. But in the spirit of great minds think alike, and there are lots of great minds on this subcommittee as well as the surge, we just want to make sure that we're not duplicating efforts. And so the SEI team members that are staffing these subcommittees will make sure and confer and communicate. And if there are any issues, we will raise them. If there were questions for the subcommittee, and Chair Shell, you were not able to be there, I think one thing you could do is just designate who from the subcommittee who would have a report on your behalf to, and then I could provide them with talking point notes of just all the pieces that came up today. So the 3 that I identified in addition to alternative medicine, specifically for veterans, was the coroners to talk about where we're missing the boat related to people overdosing. Mr. Iverson's suggestion about accessibility of treatment and the impacts of denial by MCOs, with ideas specifically potentially around an audit of Medicaid spend for behavioral health and denial by insurance for medical detox. And then I think the third one that I'm not sure, Chair Shell, if that was you or Jeff Iverson or both of you, it kind of felt like a tandem, was about the time frame for getting credentialed for therapists and the disparity in that compared to other specialties. And then your point about looking at things through a regulatory lens. particularly because the MCO contracts are up for renewal in 2025 and that the state may be going to statewide managed care.
Yes. I think that was very thorough, Kelly. Thank you. I did want to, open it up to my fellow committee members and ask if anybody would be able to speak on my behalf in the April 10th meeting. I have to be with my mother next week out of state. And so it's very likely I won't be able to attend the meeting that day. So I wanted to open it up and ask if anybody would be willing, if anyone's able to is planning to attend the meeting that day and then speak on my behalf if necessary.
Well, I'll be attending the meeting.
Thank you, Dr. Dixon. So if you wouldn't mind, if it gets to our point and we're called upon, if you could certainly speak for our subcommittee, I would greatly appreciate it.
Okay, sure.
Thank you.
Yeah, will we have minutes of this meeting by then?
Yes, Kelly will provide you some talking points.
Okay.
Laura
Yes.
will provide Kelly and Kelly will provide you, Dr. Dixon.
So thank you, Laura, as well. Any other discussion around item number 7? If not, we'll move on to item number 8, public comment. Again, public comment shall be limited to 3 minutes per person. Members of the public may comment on any matter that is not specifically included on the agenda at this time. However, no action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to subparagraph 2 of NRS 241.010. So at this time, do we have anyone wishing to make public comment?
So, and just a note, Kelly Marshall, for the record, you can raise your hand or unmute yourself during this period of time, or if you're dialing in from a telephone, 1-253-205-0468 will connect you. And then when prompted, enter the web ID 894-893-75298. And currently I don't see anyone who has unmuted themselves or raised their hand for public comment.
So I'll raise my hand for public comment.
Yes, Dr. Dixon, I'll turn it over to you.
Okay, I want to respond to the concern about credentialing by insurance companies. This isn't licensing, this is insurance companies. Is that what the issue was?
That's correct, Dr. Dixon, yes.
Yeah. Well, I just want to and I'm not going to say any names, but a conversation that I was privy to in another committee that I'm on several years ago, and there was somebody there, 2 people on our committee, and one was a therapist who was complaining about not being able to get credentialed with insurance, and the other person was the representative of one of the main insurance companies. And the representative of the insurance company said, well, the problem is you are being too picky. You only want to be credentialed for the regular insurance. You don't want to take Medicaid patients. And so we're not going to credential you, and apparently unless you do take Medicaid also. And I mean, I assume that's true, that there's a great need for people who are willing to see Medicaid patients and take the lower fees. And there's probably a lot of people who'd much rather work for employer-based insurance companies and get bigger fees.
Thank you for that, Dr. Dixon.
Uh-huh.
Anyone else wishing to make public comment? Kelly?
I don't see any other hands raised or folks unmuted.
Okay, thank you. That will conclude public comment. So before we adjourn, I just wanted to open it up one last time if there are any other comments to be made by our committee members. Yes, I see Assemblywoman Thomas has raised her hand. I'll turn it over to her.
Thank you, Chair. Just one quick question. Have we received the invite for, I believe I heard April 10th? Because I was looking and I haven't seen it.
I believe those, Kelly Marshall for the record, I believe those invitations or calendar invites should be on your calendar on April 10th. If you don't see it, Assemblywoman Thomas, let me follow up with Deanna, who's our scheduler, and I'll ask her to resend it to you. And just a reminder, you get it via an email and then you click your name in there's a link specifically for your name as a member that you click to join the meeting.
Okay, thank you so much. Thank you.
Great. Well, that will conclude our meeting today, so we can adjourn. It's great to see everyone, and we'll look forward to seeing everyone soon.